Hi dentist, how are you? This is Muhammad Musa from AFK Study Plan. Today is Sunday, and I think you know what's happening Sunday. I know the last 2 weeks we didn't do the newsletter because I was having a time off for the last 2 weeks. It wasn't planned to be 2 weeks, but like I know, life happens, so that's why we didn't do it. Thank you for asking about it. Thank you, especially Dr. Rania, because she texted asking about this newsletter. Thank you. I was like, no one is waiting for that. No one is missing it. But thank you for asking about that. I would like also to announce something. I did one-to-one session with almost 30 dentists. I really appreciate their trust. It was touching because like they told me about their pain. Some of them that do group study, self-study. Some of them take courses. They told me about the downside of the courses, good side of the courses, what they anticipate, what they want, what they really want from a course now. So generally, they all speak about the study group or study partner. So now I'm working on a good way to do interactive study group to be beneficial for everyone, and in the same time it will be time shifted, so you can edit and see whatever everyone is edited, so you can get use of your time and at the same time don't wasting your time. So I know it's a lot of time here, but like I'm working upon this. Before the next week I will announce it, so I will not waste your time more. Down here you can see the text for the question, left side of the screen the previous newsletter, upper right corner, you can click the clip and download the PDF. Feel free to give me your feedback. And this newsletter is most commonly clinical question. We will fight a lot about the clinical guideline here. I know some of you, especially the endodontists, will not love the concept and the answer, but like I will give you the reference, which is followed in North America. End of the day, it's your exam. Do whatever you want to do. Okay, let's dig deep. First question from Ortho. Premature loss of mandibular right primary second molar will lead to. Here I would like you to pause to make sure you get the correct wording, because here speaking about mandibular, so it's lower one, right primary second molar. So we're speaking about E, not D. So E is related to 6 and eruption of 6 and malocclusion happens here. So what would happen if there is premature loss? Premature loss meaning like if it's lost between like age 8 till 9, 12, 11, this age, it's premature, meaning like 6 or 5. So this is the wording, because I would like you to understand the wording for even reading the options. That's why I give you the question first and then give you the option. Class 2 molar relationship on the right side or on the left side. Class 3 molar relationship on the right side or class 3 on the left side. So let's go back to question to make sure we write the correct wording. Right primary second molar. So we're speaking about the right side. So here option for left side we are going to exclude. So now we speak about class 2 or class 3. So let's visualize it, because the problem with ortho, we don't study it well and we don't visualize it. Ortho need to visualize. When you visualize the stuff, it's easy for you. So here I give you this picture. I hope it will give you a clear view of what's going on. So we have now patient with, like I can say, I think you can see upper 6 and lower 6 in good occlusion. Maybe you can say it's class 1. And then we have E related to each other. And you see this X over the E, meaning this one will be lost. What would happen if it's a premature loss? So primary teeth lost. The Sewis molar can lose or all part of their crown as a result of caries, and this is the most common cause of losing a primary teeth. Because of pain, the remains of the tooth and root are often extracted because pedio cannot tolerate it. It can also happen that pulp infection iridial in the course of caries gives rise to inflammatory phenomena that may be dealt with extraction. So meaning like facial swelling or fistula, stuff like this, leading to premature loss, is found twice as often in the mandible as in the maxilla. So this is from a statistical point of view, mandibular teeth is lost more than the maxillary teeth. So what would happen if we lose the premature loss here? In general, it can be said that in dental arches with excessive space, the premature loss of COS teeth has a negligible effect. So as like if your child have a primate space, like space between the primary teeth, so it will not affect him that much, if any, on the future development and ultimate arrangement of the permanent teeth. On the other hand, in situations where there is no excessive space in the arches, complication in the future develop can indeed follow. Premature loss of COSTs in arch with crowding almost always has marked unfavorable result. The crowding will, as a rule, increase noticeably. Meaning, like there is through three scenarios. First one, spacing. Primary space is good, so most commonly no effect. Second one, like teeth and primary teeth are like well aligned, so it might lead to. But if the primary teeth is crowded, so for sure it will affect him. So how it will affect? So look at this picture, it will give you the whole scenario. So the lower six, it will have no stop mesial to it. So teeth tend to drift. So the lower six will drift to go mesial. So what do you think the relative occlusion, the relative relation between upper six and lower six in that side? So we speak about the right side. So the E is lost on the right side. And the six has no stop in the mesial side, so it will drift to go to mesial side. So the relationship between the mesiobuccal cusp of upper to the lower teeth, it will be different. Here you can see it's almost class 1, and the other one, it will lead to class. Yes, correct. Thank you for getting the answer. I would like you to understand it. And as in the same context, let's speak about the upper one. So if the upper E is lost, so the upper 6 will tend to drift mesially also. So it will lead to class. Amazing. I'm happy you got the answer. I'm really happy for that. Okay, what happens if like both are lost, upper E and lower E? So it will be like, it will be difficult to conclude the answer, but like most commonly it will lead to, because of we said like the lower one will drift more than the upper one. I cannot say for sure which one will lead to class 1 or class 2 or class 3, but most commonly it will lead to class 2. Okay, so here premature loss of mandibular right primary second molar will lead to at the right side, and we said the lower side, so it will lead to class 3 as the lower 6 will drift, and the relation between upper and lower molar would be misaligned, so will lead most commonly to a class 3 on that side. I hope that is clear and you understand the concept, because I know ortho is a little tricky, but like when you visualize it, when you see it, it's easy for you and you will never forget. Okay? Second question from Endo. And I know the next two questions will make a fuzz because like I know that we have a different background and we have different concept about these two topics, but like I will give you the reference because you are aiming to do the AFK exam, so you should follow the guideline followed by AFK in Canada and America and North America. So I will give you the reference. End of the day, it's your exam. Do whatever you want to do. Emergency putlpectomy is carried out for a tooth diagnosed with irreversible pulpitis and symptomatic apical periodontitis. Meaning, we are going to do root canal treatment for a tooth with diagnosis like it has positive to percussion and it has severe lingering pain or pain was hot that's not subside easily. So this is a diagnosis. Root canal is to be completed at a later visit. Which of the following is most appropriate? And here we'll ask you about the medication you are going to use. Placement of non-sitting calcium dioxide in the canals, or placement of triamcinolone in the canals, placing chlorhexidine gel in the canals, leaving the tooth open in between visits to prevent the build-up of pulpal pressure. So before we go anywhere, please, please, please do not ever pick this last option. Leaving the tooth open between visits to prevent the buildup of pulpal pressure. This is very, very, very old school, and this is not to be done at any way. Like, this is not to be chosen or picked at all, because like here you have a good intention to let the pressure go away from the periapical tissue, which gives your patient a relief. But after a few hours, the tooth is open and everything is going inside. So you are introducing bacteria from oral cavity inside the bone. And good luck to complete the root canal treatment here. So this option is not to be picked ever. So let's speak about intercanal medicament that can be used. So first of all, when multiple visit RCT is indicated, medicaments are placed in the canal in between appointment. Why? Reduce inter-appointment pain, like between the appointment pain. Medicament help to disinfect the canal. So we are aiming to reduce the pain and disinfect the canal. But which one will do which? So not everything will do both function. So let's read our option and then we can come to conclude. Calcium hydroxide is the most one commonly used. Antibacterial activity, why? Because it's alkaline pH. Recommended for teeth with necrotic pulp. No pain reduction, little benefit with vital teeth. So when the tooth is dead, like necrotic pulp, so we can use calcium hydroxide. Why? Because like here we are aiming to get the benefit of antimicrobial activity due to alkalinity of the calcium hydroxide. It has little benefit with vital tooth and no pain reduction. So this is the one most commonly used, okay? Second option is corticosteroids. Anti-inflammatory agent, useful for reducing post-operative pain, useful when used with irreversible pulpitis and symptomatic apical periodontitis, which the question is asking about. So here we are going to use corticosteroids. Why? Because here we are aiming to reduce the pain. The tooth is painful for our patients, so we are aiming to reduce the pain. If we use calcium oxide, it will be little benefit for him because here we are dealing with a tooth which is not necrotic. Patient complaint here is about pain, not about infection. Chlorhexidine, a 2% gel may be used as a medicament. Mixed with calcium oxide, usually not used alone. This combination is more effective than calcium oxide alone because like everyone as a dentist, you know, chlorhexidine is antibacterial also and it has broad spectrum. It's amazing antibacterial that can be used with calcium oxide to be getting more benefit to kill the bacteria. Last thing to be used, triple antibiotic paste, TAP, which is composed of ciprofloxacin, metronidazole, and minocycline. This mixture has been used for disinfection of the root canal system during root canal treatment and pulpal regeneration. The main drawback of TAP is tooth discoloration caused by minocycline, so they throw it in the garbage and they replace it to get the benefits, and they call it MTAP to be like effective and in the same way not causing discoloration of the tooth. So here the bottom line for this, let's go back to our question. Emergency, pulpectomy, pain, symptomatic irreversible pulpitis, and symptomatic apical periodontitis, so are going to use something to reduce the pain. First one, calcium oxide is good, but there is no infection. Chlorhexidine gel in the canal is good, but there is like here we are aiming to reduce the pain, so we're going to use something to reduce the pain, which is corticosteroids. And again, option D, not to be used, not to be picked, not to be done, ever, ever, ever. Okay? Next question from Endo also. A patient present to undergo root canal treatment of mandibular molar with extensive decay and irreversible pulpitis. After several attempts, you find that you are unable to properly place a rubber dam on a tooth. Which of the following is the most appropriate management? And again, I'm not here to fight about that, but let's follow the guideline for North America. Carry out root canal treatment without a rubber dam as long as tooth is not necrotic. Carry out build-up of a tooth using composite prior to initiating the root canal treatment. Inject liquid dam around the tooth as an alternative to rubber dam in isolation. Extract the tooth at its non-restorable. Like this is like, wow, like get it gone. Okay, so let's get this is like the paper from the NDP website speaking about American Association of Endodontics treatment standards. So here speaking about the treatment standard followed in North America. It's a very long PDF and it's a very good PDF, but like let me give you the whatever we need for this one. Consideration. General dentist must recognize a pulp and periodontal pathosis is primarily a microbial disease. Strict adherence to aseptic procedure to include the use of rubber dam is required. Strict adherence to aseptic procedure to include the use of rubber dam is required. So anyway, is required to use the rubber dams. You might think, oh, maybe not. Okay, so let's go here. So here he's speaking about the difficulty of the tooth. So we can, in the article, he's speaking about minimal difficulty, moderate difficulty, high difficulty. And you can see minimal difficulty, if you read, speak about signs and symptoms and difficulty obtaining x-ray, anterior premolar, and then first molar, and then second and third molar to be difficult. You can see in everyone, rubber dam placement, simple pre-treatment modification required for rubber dam isolation. Last one, extensive pre-treatment modification required for rubber dam isolation. So anyway, minimal, moderate, difficult, permanent molar, extensively broken down tooth, wisdom tooth, second upper seven, like whatever, extensive pre-treatment modification required for rubber dam isolation. So in any way, a strict requirement to do root canal treatment is to use rubber dam. And then finally, final consideration in root canal disinfection, the use of rubber dam is mandatory. Why? To avoid microbial contamination of the root canal system during treatment, to retract tissue and protect the patient and prevent aspiration or swallowing of instrument and limit aerosol. So rubber dam is for you, for your patient, and for the tooth. For you to limit aerosol coming to you. For the patient to protect him from swallowing the files, stuff like this. And for the tooth to prevent the contamination from oral cavity inside the bone and inside the tooth. So here, let's go back to our question. Undergo root canal treatment and you try to do rubber dam more than once, it didn't work through, so carry out buildup of the tooth using composite prior to initiating root canal treatment. You cannot even do the access unless you build the tooth. So when you build the tooth, it's good, and then you can start your root canal treatment. I know this last two questions will make a huge fuss about it, because I know some of you will not be like, no, I don't like this, I don't like that. Okay, I cannot argue with this. We are not here to argue in a scientific based debate. You are here to argue about the evidence followed by NDB in North America that you can follow. So you go to exam, you can pass. Okay? Okay. Next question from Bidu. A 7-year-old patient present into your clinic. He said, I fell down yesterday when I was trying to skate, and my tooth became short and tender when biting. So this patient giving you a scenario saying like, I had accident yesterday and my tooth feel short and tender for biting. Upon examination, you found that his upper left center incisors is displaced more than 7 millimeter into the alveolar bone. And again, here I can think we have a fight here. So when you read a trauma question, we before we said you should follow an algorithm. This algorithm aiming to get 3 information from the question before even reading the answers options. First, age. Second, the tooth. Third, what happened. Why? Because this is, well, like any change in this 3 will totally change your answer. Why? Here we speak about 7 years old, and we speak about which tooth? Central incisors. So we speak about central incisor for 7 years old patient. So if I ask you, this tooth will be mature or immature? Okay, it will be immature. The tooth like had just erupted 1 year ago maybe, or few months, and then the apex is not completely formed. So this tooth is immature. And then third information that you should aim and understand very well. So what happened for this tooth? This is like intrusion injury leading the tooth. Why is saying intrusion? Because the tooth became short. So the patient will not tell you the tooth was intruded after the trauma. No, he will tell you like the tooth is short, so you know it's intruded inside it, the alveolar bone. So what you are going to do? Immediate orthodontic repositioning, immediate surgical repositioning, leave it to spontaneously erupt, root canal treatment, then orthodontic repositioning. And this type of question used to drive me crazy because I didn't read the reference in depth. So I will give you the reference now. Let's read it in depth so you can understand the answer. So here from the article speaking about the trauma intrusion. The tooth is displayed axially into the alveolar bone. Percussion will give metallic sound like enclosed sound. So this is how we can say, okay, this is intrusion injury and we're going to deal with it. So in treatment, you can see it divided the management into 2 categories. Teeth with incomplete root formation, immature teeth. That's why I told you should aim for the age and the tooth to conclude. He will not tell you it's immature or mature. He will give you the scenario, and then you as dentist, for your background, you should get the information. If it's immature, permanent tooth, allow re-eruption without intervention. A spontaneous reposition for all intruded teeth, independent of degree of intrusion. Independent of degree of intrusion. So it's 6 millimeter, 7 millimeter, whatever it is. So independent of degree of intrusion, you are going to allow it re-eruption. Allow it re-eruption forever? No, you will give it time frame. If no re-eruption within 4 weeks, initiate orthodontic repositioning and monitor the pulp condition. In teeth with incomplete root formation, spontaneous pulp revascularization may occur. So he speaks here about not only You are going to wait. If it's not after 4 weeks, you are going to do orthodontic treatment. You are not going to initiate RCT immediately because we speak about before like intrusion and avulsion. We are going to initiate RCT. Even we do the splinting, and before we remove the splint, we are going to start RCT. No, here in this situation, you are going to wait because the teeth incomplete root formation and spontaneous pulp revascularization may occur. It's a long shot, but it might happen. Okay, so in the same reference, in the same everything, just go little down with teeth with complete root formation, mature teeth. Allow re-eruption without intervention if the tooth is intruded less than 3 mm. If no re-eruption within 8 weeks, reposition surgically and the splint for 4 weeks with a passive and flexible splint. So totally different guideline of treatment. So here we speak about it's immature tooth. You allow re-eruption if it's intruded less than 3. If no re-eruption happened within 8 weeks, previous it was 4 weeks, now it's 8 weeks, reposition surgically and splint 4 weeks with passive flexible splint. Alternatively, position orthodontically before enclosed develop. If the tooth is intruded 3 to 7, reposition surgically, preferably, or orthodontically. Why surgically here? Because like it's a huge intrusion, so we need to get the tooth out fast. Because like the difference between surgical and orthodontic surgical is fast. You're doing it now, you get the tooth out now. Ortho, it will take time. It will take maybe at least 4-6 weeks the tooth to go out. If the tooth is intruded beyond 7 mm, reposition surgically immediately. So are not going to wait. So the question here, you see it's more than 7. So you jump to reposition here because you didn't read the question well. You didn't follow the algorithm. When you follow the algorithm, you make life easy. In teeth with complete root formation, the pulp almost always become necrotic. Root canal treatment should be started 2 weeks or as soon as possible as the position of tooth allow, using a corticosteroids, antibiotic, or calcium oxide as intracanal medication. So I hope this is clear. That's why I told you before more than once you should read the question carefully, especially the cases question, so you get the answer from the question. When you read the keywords, it will be so easy to get the answer. And please, when you read the reference, because I see people sending me screenshot like this is said that, this is said that, you should read the fine details. When you read the fine details, it will be easier for you to get the answer correctly. So here we are going to leave it to spontaneously erupt. Why? Although it's 7 mm, because we speak about central incisors and 7 years old, which is immature tooth. Hope that was clear also, okay? Last question, Dave, from implant. Which of the following statement is true? Honestly, I hate this type of question because like it like when you read question, you feel like, okay, I'm going to focus about this topic. You are going to remember this, remember that, but like which of statement is true? Like boom, like get you in open ocean and like swim here. Smoker should never receive dental implants. I think this is can throw it into the garbage, like because like words like never, like this is very strong statement. Okay, and here let's like ask you a question like what is the complete contraindication of dental implant? I hope you can answer. Please answer it and give it to me in the comment section. Smoking improves the prognosis of implants due to reduction in gingival inflammation. So the first part of the sentence is like making no sense at all, but the second part is correct because like the the negative side effect of the smoking, it reduces gingival inflammation. Why it reduces gingival inflammation? Because like nicotine and the hot smoke inside your mouth, leading to less vascularization and less ability of the tissue to respond to the bacteria around it. So he will have less bleeding and the probing depth, stuff like this, but it will have inflammation, but not like the general like way of inflammation with other people. Smoking cessation 2 weeks prior to implant surgery is beneficial for increasing wound healing. I think this is the correct one. All of the above. So we said like A is for sure not correct. So D is not correct. So we speak about B and C. B, the second part is correct, but like this is not leading to improve prognosis of implant. So I think it's easy for you to conclude the answer here. Smoking cessation 2 weeks prior is beneficial to increasing wound healing. And here let's speak about the healing after implant because this is critical topic. So primary mechanical stability is within 24 hours. In first 24 hours, this is extremely critical. So you cannot let the patient go home unless you have good primary mechanical stability. In the first few weeks, you will be using only the mechanical stability. And then On the fourth day, what's going to happen? Because you did a trauma for the bone inside this area, so the new vessels will try to remodel around the bone, around this tooth, around this implant you did. And then on the fourth week, there will be temporary loosening. Why? Because of the remodeling happening here, there will be bone loss and bone gain. The bone will be remodeled, the bone osteoclast will work around this tooth, around this implant to eat the bone and lay a new bone. This is what we call osteointegration, starting in fourth week and then eight up till 8 weeks. In this one, you will have temporary loosening of the crown, but like it will be good. But that's why we don't put the crown immediately. We wait at least 2 months to 6 months, depending on the bone type and the initial stability, the initial number you had during the first insertion visit of the implant. It will give you the reference for how long you're going to wait. And then secondary stability after 6 to 8 weeks. And here, when the osteointegration, I cannot say completely done, but like here starting, the bone is remodeled now, removed, and then the new bone is going to be built around the dental implant, leading to what we like to call osteointegration. So let's here see this timeline, because this timeline, it will be easy for you to remember. So if you look up here, the blue line is speaking about the total stability. So in the fourth week, between the third and fourth week, there is a stability dip. And I think now we understand why this is happening. And here we speak about the primary stability and the secondary stability. Primary stability, we call it old bone. The primary stability at the day of insertion will be 100%. That's what we are aiming for. And then it will go down, 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 down. Why? Because as we said, bone remodeling is happening around the dental implant. And the fourth week, we have stability dip because of the secondary stability, which is new bone, is not developed yet. It's still growing up, growing up, growing up. Starting from the fourth week, it will go vice versa. The primary stability will be in downhill, and the secondary stability will go uphill till it go to 8 weeks. And at 8 weeks, at least we can say osteointegration, we cannot say completed, but like in a good way now, in a good way, at least leading to the stability which we started at the first visit. And again, all that is theoretical. Like if the patient have bad oral hygiene, he got smokes again in this area, he got smoke here and there, he is drinking some stuff. So oral hygiene is extremely important factor. But here, like we're speaking about like the general guideline. That's why you here to see these two boxes: implant rated factor in the first 4 weeks, and then environmental rated factors starting from the third weeks and going forward. So I hope the idea of the bone and osteointegration around the tooth, around the implant, is clear for you here. So the guideline general for implant and smoking, we can do implant for a smoker for sure. Ideally, the patient is instructed to cease smoking for 2 weeks. Why? To allow time for the gum to regain its normal vascular supplies, because when it regains the normal vascular supply, this will like lead to more favorable outcome in healing after the implant. Smoking cessation is continued for 8 weeks after implant surgery, and I think you know now why 8 weeks, which coincide with the osteoblast phase of bone healing. This has been shown to increase wound healing capabilities. So go back to our question to get the answer for the last one today. Smoking cessation 2 weeks prior to implant surgery is beneficial for increasing wound healing, and we can say 8 weeks after the implant surgery, so we can make sure the osteointegration at least in a good shape. I cannot say finished. I would like to say finished. I cannot say finished in 8 weeks. That's all for today. I hope you will not make a fight with me about this into a guideline, because this is what is followed in North America. Hope you understand it. Hope you can read the articles. Hope you can read the guideline. Honestly, it makes sense when you think about it and be like honest, be scientific, following scientific based dentistry. You will see it's making totally sense. This makes sense. Okay, thank you very much and see you next Sunday.